Healthcare quality is another emerging issue amongst employee benefits. And the reason is if I'm offering an employee benefit of healthcare, I want it to be good. I want it to be a good quality for my employees. And so one of the challenges that we're having in the employee benefits field is quality of care. So when I, as an employer, am looking at the employee benefits package and the type of plans that we'll offer for our employees, how do I know what service providers I'm offering to my employees? How do I know that they're good quality? How do I know that I am purchasing the best product for my employees? Because we don't really have a lot of things that are capturing what constitutes good quality healthcare. There aren't a lot of explicit factors. And so why not? Because there's a challenge in measuring it. What are you measuring? There's a lack of technical knowledge from the employer perspective and just a lack of impact. There's some great resources being built to help employers see what constitutes a good network, who should be in your network. And one of these is the Leapfrog group, and they are not connected to any particular organization. So they're a bit of a neutral third party that evaluates hospitals, facilities, and other like surgical locations. So if I typed in Caldwell, we would see how they measure up to the different standards that they have in their system. So here you can see they've done some really good risk control of avoiding harm, using appropriate use of antibiotics, responding to particular events. Medication, they seem to be doing okay in. How are they doing related to hospital infections? Doing okay, not great, but doing okay in comparison to some. You can look at their maternity care, you can look at their pediatric care, and their critical care. So if you're looking at how a hospital performs in a particular area, you'd be able to see all that in this Leapfrog rating. And again, why does it matter? Well, failure to have good quality can come back on you as a company for neglecting your corporate social responsibility of providing quality benefits for your employees. So think about this. As an employer, you're aware of the importance of quality in healthcare purchasing. How should you go about assessing the quality or promoting employee evaluation of quality at all levels of care? Looking at physicians, are you looking at physician licensing, credentials at hospitals, evaluating physician malpractice claims because a repeat history is fairly likely? Like, what should you be doing as an employer to address these issues? So looking at primary care, why has primary care continued to deteriorate in the U.S.? Well, probably before now, you didn't even know that primary care was a deteriorating component of healthcare. But there are fewer younger doctors that are pursuing primary care practice. The money just isn't in it for them. And nor is the specialty and the challenge that is in some of the specialty fields. Practices are financially insecure. The PCPs are required to focus on productivity, so it becomes less about the quality of care and more about how quickly you can get through your patients for the day. And medical practices with primary care have evolved over time, but really lacked integration into other specialty areas. And this is something that some other countries seem to do better than we do because they have a stronger primary care basis and then they have less people in subspecialties. We have complex medical organizations now with medical directors, chief administrators, committees, and everyone's working under this like major hospital, board of directors. And so what we've seen is some PCPs are moving to an area called medical homes. And if you click on that hot link, it'll take you to a video that talks a little bit about what patient-centered medical homes are. And it's really a way to centralize care and almost returns a little bit to the HMO model. So let's take a little bit of a look at networks. So in the late 90s, tight restrictions on out-of-network benefits were loosened in response to consumer complaints. There are a lot of complaints coming out. And as a result, in 2010, 79% of enrollees were either a PPO, POS, or CDHP plan, all which allowed out-of-network benefits. So the advantage of an out-of-network coverage was that there was a potential to reduce costs and improve quality by allowing health plan members to seek these out-of-network care. Problems with that out-of-network care were pretty significant, including things like unexpected and significant out-of-pocket costs due to lack of information on the network, not knowing the doctor, if the doctor was in network or out of network, and I'm going to talk about that here in a moment. Non-transparent out-of-pocket costs, inadequate networks. If you think about some rural areas might not have had adequate network services. Involuntary use of out-of-network care during emergencies. If I'm in a rural area, perhaps that doesn't have an in-network provider and I have an emergency, I need to go somewhere. So I'm going to have to go to some place that's out of network. The use of out-of-network providers in network hospitals, which we're going to talk about here in a moment, as drive-by doctoring, and consumer protections that are currently inadequate in most states to deal with the fact that we have so many issues with in-network and out-of-network setups. So that takes me to this drive-by doctoring concept. And if you could pause and watch the video that's posted here, because it gives you an example of what drive-by doctoring looks like. So essentially, drive-by doctoring is where you go in for an in-network hospital. You see an in-network physician who says you need this surgery. At some point during the surgery, something goes wrong, and now you need a consultation by another physician. They call this physician in. That physician happens to be out of network. Procedure's done. You weren't consulted, nor did anybody clear it to figure out if that physician was in network or out of network. And then you get hit with the bill. You don't have any say in it, but you're being charged significantly more because you used an out-of-network provider, or the hospital used an out-of-network provider to consult or assist your in-network physician. The challenge is this legal? And can it be done to protect, what can be done to protect unsuspecting patients from these kind of horrific practices? Unfortunately, there aren't real good answers to either one of those yet. But it is an emerging issue that employers are having to deal with because their employees then feel like their networks are inadequate. So what costs do members face when they go out of network? Obviously, they pay a higher copayment. We saw that in one of our earlier charts. So usually the copayment can triple or quadruple from what it typically is. Higher coinsurance, because you may be in a in-network plan, you have an 80-20, meaning you have a 20% coinsurance. But when you go out of network, it might move to 70-30, in which you would have 30% coinsurance. The member then could be responsible for balance billing charges, meaning that the HMO might, or whatever insurance coverage may pay $60 for a procedure that is being billed at $100, and so then you're still on the hook for $40 plus whatever your coinsurance was on that $60. And insurers all have different ways of how they deal with paying those out-of-network costs. Out-of-network providers are not bound by the insurance rates set by the insurers, so they can have a balanced bill to a patient, and there's nothing that the patient can really do about it. Balanced billing is essentially additional amount owed beyond the copayment and the coinsurance, so that can be a lot for an employee. And again, it's an employer issue because it reflects on the quality, even though it's unintentional, the quality of the benefit that the employer is offering. So in some cases, the out-of-network provider is just not an informed or voluntary choice. So the consumer may not even know if they are in-network or out-of-network, or whether the consumer will be balance billing. It's not something you're asking as someone's getting ready to cut into your, into your leg because it's broken. In some geographical areas, the network may also be so limited that members have little choice and then have to be compelled to use out-of-network providers if they want service at all. Emergency services may be provided by out-of-network providers. In an emergency, often consumers must go to the nearest emergency facility, or the ambulance just may be required to go to a specific hospital. And consumers then are balance billed for the ambulance service as well as the emergency room service. And again, we're starting to get into the thousands of dollars here. And while some plans don't hold that the consumer should be responsible for paying additional out-of-pocket or out-of-network charges, some plans do. So the argument for balance billing, it's really to help compensate emergency room departments for routine underpayment by health providers. The second argument in favor of balance billing is that doctors are required to serve emergency room patients under the Emergency Medical Treatment Act. So they believe that they should be paid the prices that are listed based on that. Insurers then argue that the list price charges by emergency room departments are really just unreasonable, so they're not going to pay it. In some cases, hospital-based providers such as anesthesiologists, radiologists, the folks that are typically not chosen by a consumer, are sometimes out of network, even when the hospital is in network, like we saw in that example in the video. Aetna was recently sued by, I think, some New Jersey physicians for unconscionable fees at an in-network hospital, including a $50,000 fee for an inpatient cardiology consultation, not even a surgery. There's a lot of lack of information on network participation and costs. You have outdated directories. I think one study showed 25% of phone numbers and addresses were incorrect on the directories that were being put out. Now, of course, online directories help curb that a little bit. Consumers can also find it difficult to uncover the cost of going out of network, challenges in obtaining good cost information. Again, that everywhere else where you see prices laid out, we don't see them laid out at the hospital. Most providers don't publish those prices. Most insurers don't publish their out-of-network reimbursement rates. So just kind of a lack of information overall. And we've talked a lot about network inadequacy. Providers are less likely to join a plan if they don't see a benefit in joining a plan, and so they're not going to, go. They feel like they have more negotiation power, so they're just going to hold out. And then again, geographically, but also by specialty, if I am the only provider in town that's a neurologist, my need to negotiate to get your special rate is less. So there are some policy solutions out there as we look at drive-by doctoring as an emerging issue. Federal and state lawmakers have been attempting to address these issues. Some have done well, some have not. Transparency is really the goal, right? We just want to know how much stuff costs. We know it's expensive, but at least tell us how much it is and how we can work through it. Healthcare reform really requires some plain language to explain in and out of network benefits. We've seen some changes in summary of benefit coverages. The one I get from Blue Cross Blue Shield now is color-coded and really plain and easy to read for most folks. And then state health exchanges may be helpful in providing some important cost-sharing information and better tools to access different types of coverages. The ACA approach to emergency room care and regulating insurers, they took a stab at it. They don't require enrollees to pay higher for out-of-network ER care than what they are receiving, and they reimburse emergency room care in the highest of the amount the insurer negotiated with the in-network hospitals and whatever Medicare would pay. So that's how the ACA has dealt with it in their marketplace programs. So there are some tools that employers are finding in the insurtech space. One of them is called HealthJoy. And HealthJoy is an incentive program. It's an app on the phone that allows employers to offer rewards to their employees for using fair price healthcare services. The app's kind of cool that it allows the employer to customize their rewards, and even helps reduce in-network costs for some procedures by like 10% or by like 10 times. And of course, the return on the investment for some of the earlier tests that they did was like 6 times the savings. So here's a snapshot of what the platform looks like. So it's almost like Rate My Professor, where we have the name of the surgeon, how many stars they're getting, and this is how much you'll save. This is how many rewards dollars you'll get if you use this person versus any of these other ones. Again, they have the same rating. But they probably are charging something different. And so the employer may say, hey, if you use this person, then we'll give you $400 of reward bucks. It doesn't stop you from using this person, but this is just the extra incentive. And so here's why they're recommending them. They're the nearest network provider. They have high patient ratings, and they have the earliest availability. And so look, it even gives you down a breakdown of here's what the average cost of that procedure is in this area, and here's the estimated cost that this person is going to charge. And so then you can see where this person was able to, because each one of their services that they booked through this, they're able to earn points to then redeem in their reward shop or whatever it is. So it's kind of a cool tool for employees. When we think about HDHP plans and what their goal was to really put things back in the hands of the employee, this is a tool that would do just that. And so it's kind of a neat project. And then, of course, it gives you all the reviews and consolidates some of those doctor reviews. I think the article that I found broke down HealthJoy into 3 areas: shop, save, and earn. Shop, the HealthJoy members already ask every day to confirm or find out thousands of high quality, fair price in-network providers for a variety of procedures, and now they have that extra incentive to ask for advice. Savings, recommendations that are reward eligible contain a badge with each incentive amount. Then the members also have access to the HealthJoy Reward Center that shows the completed and open rewards, which is over there on the middle. And then in the right, earn, members can submit a photo of their EOB or bill to verify that they followed our recommendation. And then HealthJoy can also work directly with cooperating third-party administrators so the employee can skip that step. What's really cool about this tool is that they're going to expand into, or they were supposed to expand into, prescription drugs this year. And as we get to Unit 3, we'll see why this tool would be great for something like prescription drugs. So we've spent some time talking about in-network, out-of-network, and all the pricing challenges faced in like drive-by doctoring situations. So when we look at our U.S. healthcare system, it's really well known for having lack of price transparency, not just in healthcare, but also in pharmacy benefits and some other areas. And so some self-insured employers are really responding by using this reference-based pricing model with doctors and hospitals, which is kind of setting their own prices for healthcare services. So reference-based pricing is essentially a cost containment strategy that pays doctors and hospitals a percentage of an established benchmark. And that benchmark is often the Medicare pricing. So like 120% to 300% of Medicare is what they're willing to pay for a particular given service. Of course, some of the pros is that it eliminates networks, but some of the cons is that if there's not a particular contract with the hospital, you could still end up with some providers that aren't willing to accept reference-based pricing for payment in their services. So then we still have the balance billing issue. I know this model is being tested and used in the pharmacy benefit space as well to control cost of pharmacy benefits. And a lot of them are using the same model of a certain percentage of what Medicare would pay. Again, kind of like that government floor of payment. Last year around this time, North Carolina, the state plan was in a big battle with major network providers because they wanted to offer this reference-based pricing plan for state workers. And it didn't go over so well for obvious reasons for some of the major providers that are out there. And ultimately, North Carolina wasn't able to pass the reference-based pricing for state employee health plan. What's interesting is that Montana was able to do it. And Montana's done some pretty amazing stuff when it comes to their healthcare and in general. Montana seemed to be fairly tired of letting insurance companies and hospitals run the show in their benefits administrations. And so Marilyn Barlett, who's spoken to my class a couple of times, she pretty much called all of the insurers on this reference-based pricing piece and was able to get it passed in Montana. And I think they've saved, $13 million over the last 3 years. And they've also done some work in pharmacy benefits as well in controlling the costs with their pharmacy benefit managers. But, North Carolina just wasn't able to get the traction that they needed to make reference-based pricing work. Hospitals claim that, they have 130,000 state employees in North Carolina and it would ruin their profit margins, causing them to go bankrupt. And ultimately, I think that the state treasurer just didn't have the training that Marilyn Barlett had regarding this approach. And so North Carolina's compromise essentially removed the incentives for hospitals to agree to reference-based pricing and basically left it to where the old plan was pretty much what stuck. So we're still using networks in the state of North Carolina. And so I'm going to wrap this up by giving you a bit of a preview of what the next series is that we're going to cover under Unit 3. So in the early days of healthcare, prescription drugs represented a small portion of our overall healthcare expenditures. But today, pharmacy benefits probably represent 20% or more of a healthcare budget. And payment for these benefits has become so complex that insurance carriers carve out what they call the RX benefit to a pharmacy benefit manager or a third-party administrator who pays the claims and then reimburse the pharmacies for dispensing the drugs. There's a lot of other behind-the-scenes functions that we're going to get into in Unit 3 that's pretty intricate and pretty interesting. And then when we look at mental health and substance abuse benefits, historically, those benefits have been more restricted and limited and could easily cap out. But due to some of the healthcare reform that we've seen at the state, federal level, those benefits in that category are now parity with other benefits in medical plans and can't have the same restrictions that they did before. So some interesting things to look forward to in Unit 3 there. When we look at healthcare reform, that was enacted in 2010 with the reforms taking place over a 10-year period, we see them, referred to by many, many acronyms: the PPACA, the ACA, the HCR, the Obamacare, whatever you want to call it. And so it really eliminated pre-existing conditions being an issue in healthcare and being able to remove those. And then the elimination of lifetime maximums that I talked about earlier. No longer can you cap out of a plan because of a massive event that, that would render you to have spent, $1 million in healthcare expenses. There's certain preventative services that have been covered without copays or deductibles, such as annual exams, mammograms, colonoscopies, some child immunizations, wellness visits. It may not be a big deal to some, but it's a big deal when you can't even afford the copay to go see the doctor on a regular basis. And it established this marketplace exchange to make available adequate standard medical plans and affordability. And again, some of the pieces that I mentioned about how they attempted to deal with ER care and costs. So, how does healthcare reform impact employers? Well, in a lot of ways, employers must pay or play. These medium or large employers must offer affordable and adequate coverage or pay the penalties. And as we saw in the Unit 1 material, how the ACA intersects with some of the existing laws that are out there. Employers must cover essential health benefits, and that definition varies by state. And plans can no longer have these lifetime maximums, which means that their out of pocket could be quite a bit. So self-funded models have to really think through that. Plans must have certain services covered as a preventive service at 100%. Small employers have temporary tax subsidies that they were able to get if they offered group health plans. And there is just a ton more administrative and reporting requirements on an employer. So the ACA had a lot of challenging implications for them, and of course had some challenging implications for employees. And then in some areas had some benefits to folks who wouldn't otherwise have received benefits. So, like every other piece of legislation, it's got the good, the bad, and the in-between. And that will do it for this unit. Hooray!